Hello, my name is John Faithful-Hamer. Welcome to the Likeville podcast. This evening, we're going to be having a conversation with Francis Fortin, a friend of mine, very interesting person, real sort of Renaissance man, an accomplished photographer, videographer, artist who has decided to go into medicine and believes that there's all sorts of interesting ways in which you can bring the sensibility of an artist and a philosopher to medicine, and specifically radiology. Anyway, I have lots and lots of questions for you, Francis. But welcome to the podcast.
Thank you very much. Glad to be here.
I just want to start with some sort of more global questions before we talk about specifically your case, right? John Ralston Saul, the Canadian philosopher, in Voltaire's Bastards, he has this long, angry rant about doctors in our society, in North American society, and actually he's sort of applying to the West in general, but he specifically says North American doctors. And he says, what has happened to the medical profession where, if you go back to the 18th century and the 19th century, doctors were really, really prominent and important citizens. They were involved in all sorts of movements. They were involved in politics. They were prominent they really took their citizenship seriously. And he said, now these days, doctors tend to be very much kind of concerned just with their specialty, and they don't really contribute much. And when they're on their free time, he says, all they really do is read a bunch of formulaic thrillers. And, and he says, is your experience that there's a kind of a myopia? Because I know you're somebody who's interested in a lot of different things, and you've always been like that. And I'm wondering, do you find that medicine is more prone to specialization than anywhere else, or is it pretty much the same thing?
It's a good question. I think a lot of people in medicine, at least the people I've been around, have different interests as well. I mean, there are various high-level athletes. There are even Olympians who are also doctors. In Quebec, our prime minister is a neurosurgeon. The health minister is a radiologist. So there are people with interests, and I have friends who are very involved in all sorts of student associations and medical associations and all sorts of other social causes. There are even medical specialties, which are, I'm not talking about specialties again, but where people are actually studying health population, and those people are obviously more into activist causes. But I'd say most of my friends also have a bunch of other interests as well, and not just medicine. But of course, as with any field, I think as the field evolves and knowledge just never ceases to increase, and medicine has been one of the cases where publications have just gone up exponentially in the last few years, it's inevitable that people will get more and more specialized. And that's, I think you've mentioned that before in other podcasts about the problem with specialization, and this obviously applies to medicine as well. And as you go deeper into the field and people want to get better at their field, and there's just so much breadth of knowledge, there are over 100,000 of publications every year in the medical field. So if you want to stay ahead and if you want to be good, and also I think ultimately good for your patients, then you have to spend a lot of time doing that. But that doesn't preclude in any way that people have a ton of other interests as well.
Okay. It's funny you mentioned the whole issue of keeping up with the profession, because I know one of the things that my personal doctor, is also actually a friend of mine, and we've had a lot of conversations about this issue. And he said, well, because things are changing so rapidly, very often, if you got your medical degree, let's say in the 1980s, well, the conventional wisdom on all sorts of things has changed dramatically. So if you're not keeping up with the literature, if you're not learning on an ongoing basis, then you could actually be giving your patients all sorts of bad advice, right? And that this is right. So do you find that in your experience of medicine so far, do you find that the older doctors, do you find they're older and wiser, or do you find that a lot of them are out of date? Their knowledge is starting to sort of past its best before date?
A little away. I'd say most of them. I'm probably biased, obviously, because I'm still doing my specialization. So a lot of the doctors are in academic centers, so they have reunions every dinner. There's like sort of like journal clubs and all sorts of activities to stay up to date. And most of these people are also involved in research, so they go to international conferences, and so most of the people I've worked with are up to date. I'm pretty sure it's a huge bias. Obviously, if you go out into more rural areas where there are a few family doctors for the whole village, these people obviously still have mandatory accreditation checkups, and they have to do all this like minimal training every single year to keep their diploma and
their certification
to practice. And it's a yearly thing, and it's actually many hours. So I think most people do still stay up to date, but obviously there are some things. For example, if they didn't attend a conference specifically that deals on, I don't know, this type of disease they come across very rarely, then they might not be doing the most modern recommendations. That's for sure. But I'd say most doctors stay up to date. But to give you an example of how crazy it is, I mean, you talk about doctors who started, say, in the 80s, or you take like the 70s. A lot of these people, when they started practicing, MRIs didn't even exist, right? So the MRIs came on later around in the 80s. So these people at first, there were no MRIs, and now it's sort of unconceivable for you if you have any neurological problem to not get an MRI almost. Most people come to the hospital, get a CT scan, unless it's quite obvious on the CT scan, will eventually have an MRI as well. So it's just become common practice for many things, has completely shifted to things that didn't even exist when you started practicing, which is scary because there's so much stuff to stay up to date with, but it's also very exciting because it's a rapidly evolving field. And so I think at least the people I'm working with in academic centers are quite excited about that and all the developments there have been.
Well, with all these new developments and with all the all the journals you have to read in order to keep up to date and stuff like that, what is the role that sort of computers play in this? Like, do you have some sort of like an app on your phone, or do you have like a computer that you use that kind of helps you in your diagnosis, or is the idea still that you're supposed to, in medical school, just absorb all of this information and then go out in the world and kind of practice medicine, and you're just doing it, like Gregory House, right? Just like from your own brilliance, diagnosing things? Or do you use various kinds of databases or programs?
I wish we could just soak it all up. I mean, every day, even our attending physicians and every single resident I come across is always checking out stuff online. So there are a ton of different medical apps, and there's resources like Up to Date and stuff like that. These are just like these people who spend a lot of time just they have librarians, and they just check all the newest medical publications and researchers, and then they make sure these texts are up to date every few months. So. And most of the people I work with are constantly checking these things. For example, diagnostic radiology, every single day I'll check at least 10, 20 times some website. Just look at this diagnosis, and you think it's that, but what if it was something else, right? So you'll go look about differential diagnoses and stuff like that. So, and this is even more true for certain fields like cardiology, where things are changing so fast that you just need to stay ahead. And these people are always there's a bunch of apps on websites and all that stuff.
Okay, well, I imagine you could see where I'm going with this, but like, what do you think about Watson and various kind of artificial intelligence that they say could totally replace doctors? Like, we could have, and this, if you had an artificial intelligence, somebody like Watson that has memorized everything, so it never forgets anything, and is totally up to date. So if there's a change in kind of the literature, this sort of artificial intelligence knows it right away and what do you think? Could something like this replace doctors, or would you want to sort of partner with a artificial intelligence that could maybe, I don't know, be your consultant, and you'd say, "Hey, Watson, what do you think about this? I think this is the right thing to do." And Watson could say, "Well, clearly you're tired from last night because you're forgetting this symptom and this symptom." And what do you think about all that?
I think in the past few years and even the past few months, the excitement's gone up for all things artificial intelligence. In my field in radiology, it's not something that's coming. It's something that's already here. It actually exists already, and we have different software that work actually quite bad and poorly. So to be honest, I'm really not scared of losing my job in my time. Perhaps one day there'll be something better, and if there is, I'll welcome it wholeheartedly. I'm working calls, nights, weekends. If there's something at 3 a.m. they could just do the most of the job for me, I'm all for it. But to be honest, so far the results for me, what I've seen, have been disappointing. And this is having gone to the biggest radiology conference in the world, actually, in Chicago, this past December. There's a lot of excitement about it, but objectively the results are very subpar. And so far, there are things that exist, for example, where they'll demonstrate that for a very limited application, doing specifically one thing, the machine will outperform humans, which is great. For example, you're doing a CT scan of the chest, and you want to look if somebody has tiny nodules that might one day become cancer, and this is part of lung screening. And they found that certain types of AI algorithms are better than humans at detecting a certain type of nodule, not even just nodules in general, a certain type. And it's something like the computer will get 85% of them, and the average radiologist will get like 75. So I mean, okay, it's not a huge difference. But this, regardless, this is the type of drudgery, boring work that we don't want to do anyway. So like finding these little things, what we want to do is, when patient comes in, the clinical team, for example, is very concerned about, what disease does this patient have? I don't understand. And they'll do a CT scan, and then you get to find like, oh, there's this tiny thing, and there's also this, and there's all these other findings. And when I put it all together, it comes to this diagnosis or this thing, and you should try to do this test and try this drug. I don't know. So this is like very, very broad example, but so far there are no AI applications that come even close to this. The best AI so far is still very, very, very rudimentary. And I think that even what happens is that we have, for example, I don't know how many, this is more than thousands of different diagnoses in medicine and different diseases that we've categorized, and all of them have different manifestations. And on either clinical findings or imaging findings, you can have a ton of different manifestations for the same disease, and oftentimes these manifestations are non-specific. So there's a mass in somebody's chest, it can be a ton of different things, and there's no way by imaging that you could so far say what exactly it is. And so these AI algorithms, they're good at, for example, finding if there is a nodule or not, and then they output one value, which is yes or no, right? But they can't help you say, does it look like cancer? Does it do this? And so far they've only been able to do very, very limited things. And I read an article about artificial intelligence once, which was very interesting, actually. It's a dermatologist who said they have this application where you can take a picture of a skin lesion, and then you put it into the system, and it tells you with better probability than if it was a dermatologist if it's melanoma or not, which is great, right? Because melanoma is one of the only, or definitely the most frequent, deadly skin cancer. And so the dermatologist, when they interviewed her, she was like, great, if I can have this, I would use it because it can help me make better decisions for my patients. But that's not going to replace the dermatologist. It's just going to be another tool to help you, right? So you can think of the stethoscope when you got, better stethoscopes. You can help me listen to the heart better. But that's not going to replace the cardiologist, right? Because there's still the whole patient interaction. The person, when people explain their symptoms, they come in, they're sick. They're not like entering it into a text box and saying like, I have chest pain for the last 3 days, and something that a machine can understand anyway. And then eventually you need to try treatments, and you need to see if the person's doing better. And there are all these things that computers cannot take into account. For example, when you go see somebody and they say, oh yeah, I'm feeling better, but you look at them and they really don't look better. This has like happened many, many times in my training so far, and seeing people, and you just sort of have an intuition that they're not doing well, and then you'll change the treatment, you'll do something else. So oftentimes I feel these computer algorithms where people like, is the patient doing better today? You check yes, and that's not going to work, right? So there are all these human variables so far, and just the warmth of a human caring for you, that's not something that a computer can replace. So for me, if AI applications, although I don't really believe in them so far, what they've been, the people who get most excited about them is those people who are looking for funding for their research, or funding for their startup company or whatnot. But if they do become integrated into clinical practice, I think that's all the better, right? It's just going to be more tools for us to better treat our patients. So,
okay, what is your sense? When I was a kid growing up in Quebec, the healthcare system here was fantastic. It was absolutely fantastic. It was very easy to get whatever kind of care you wanted, very high quality care. And then a number of things happened. First of all, right under the Liberal governments, but they cut a lot of funding to healthcare. They decided we were spending way too much. They said we needed to have less doctors, less nurses, all this stuff, right? And the end result is that now it's really, really hard. If you're coming from out of the system, if you don't have a connection, if you don't have an in, right, it's very hard. And I know I talk to a lot of my students who are in families that are recent immigrants to Quebec, and they say it's incredibly hard to get a general, like a family physician. It's really, really hard to get into the system if you're outside of it. So they end up going to these CLSCs, to these clinics, waiting for hours and hours and hours. And when they get in there, they're seen very rapidly by somebody who just wants to see as many people as possible. So they get seen for, 5 minutes, 10 minutes, rushed. So they're not getting much of that human interaction you were talking about. So I'm curious, do you have any ideas about what has happened to the healthcare system that has made it sort of decline so much from what it was just a few decades ago?
It's kind of hard to say. I don't know, to be honest, if it's declined so much. I know when we think back, we often remember things better than they were. I do, however, acknowledge the fact that it's hard to get into the system. I think the Quebec healthcare system, once you're in, if you do have a serious condition, if you have a cancer, whatever, you have concerning disease, then the treatment you'll get is excellent, and it's comparable to any European system and better than most of what you'll get in the States, which is sort of like high cost experimental stuff, which hasn't really been proven yet. So I think the healthcare system in Quebec, once you're in, like I said, is very good. However, there are barriers to access to that, and to be honest, I don't know what the causes are, right? And I'm kind of confused because when you look at the statistics, Quebec has as many doctors as other Canadian provinces. However, wait times are longer, and there are various different factors that make it hard to just see a doctor, right? And especially when you compare to certain European countries. However, I don't have a good explanation exactly as to why that is. There are different factors for sure that affect certain wait times. I know that physician location is one of them. And for example, when I was working, I was doing a rotation in family medicine in Cowansville, right? So about an hour drive away from Montreal. And there was a CLSC there where I was working where they were actively looking for patients, right? So it depends what geographical area you are in. And Montreal is by far the hardest place to get a family physician. But if you're in other sort of more rural areas, then there are places which are actually actively seeking patients. And this one doctor I was following, he only had like 500 somewhat patients, and he would schedule clinics for me and only put 4 patients. And I'm like, I can easily see 10, in a day, even more than that. But there aren't people coming. And regardless of that, what very much frustrated me is that people who are waiting for months to get a family physician, to give you an example, during that rotation, most of the times if I had 4 patients scheduled on a day, only 2 would show up. There are so much absenteeism from medical appointments you would not believe. Right now I'm doing ultrasounds
I've never heard about that before.
At the SHIM hospital, and every day about 20% of patients don't show up to their appointments.
Oh, wow.
So there are obviously administrative problems behind that. Maybe people aren't getting their appointment letters. I don't know exactly how. Honestly, I don't know how the appointment system works in every place, but some places still send letters. So which is, I mean, you have, maybe you changed addresses, you move, whatever, and your consultation for a specialist, you sent it in about 6 months ago, and by that time you're never going to receive that letter, right? So I think there are definitely things that could be done to improve just the compliance with the appointment. If people just showed up to their appointments, then we would actually be much better off. But I swear, when I was doing that CLSC, like people in Cowansville, well, it was a small city around Cowansville, it doesn't really matter, but about half of them wouldn't show up. A third to half of them would not show up. And oftentimes this was like your first appointment with your family physician who's willing to follow you for the next 30 years because he's a new doctor, and people would not show up. And it would just drive me crazy. I couldn't understand how I have friends and family, and even I myself don't have a family physician, and they're just waiting to get a family doctor. And meanwhile, you have all these people who are not showing up to their appointments. And there are obviously exceptional cases, like the 90-year-old woman who can't get there by herself, and then her son can't bring her because of a work thing. I mean, there obviously, if you're working with people, there are always going to be people who can't show up to appointments. That's fine, but I find the rate of no-show is absolutely mind-blowing.
Wow.
Because if you can, for example, just right now in ultrasound, if we can get like 20% of our patients who don't show up to show up, then our wait times will just reduce by 20% right away. Yeah. Because these people, we have to reschedule them. And oftentimes it's be like, they won't show up once, and then the second time either, and the third time they'll show up. But every time they're taking up somebody's spot, right?
Yeah.
Which is to the point now that they over-schedule. So if everybody shows up, which I've never seen happen, but if more people than expected show up, then we have like more wait times, right?
Yeah.
So, but there are definitely administrative things. For example, not everybody has email, but if people who do give an email address could just get an email reminder, I think that would be great.
That would speed it up.
Because calling people is long as well, right? They call you, and you often give your home phone, so they call you during the day, and you're not there, and you don't get the message. And so, I mean, there are definitely ways to improve it. And I don't want to put the blame on the patients for the wait time, but it's just my perspective as a healthcare professional, as a doctor, seeing how people don't always show up to their appointments.
Well, that's something I've never heard before. Yeah, definitely.
Yeah.
But,
and
so
I think
I want to actually just rewind for a second. Why did you, of all the talents that you have and all the interests that you have, why did you decide to go into medicine? Like, what was the appeal? I mean, neither of your parents are physicians, so it's not like it's like, oh, I'm doing what mommy's doing or daddy's doing. Like, what made you want to be a physician?
It's a good question. There are many aspects to it. I think one of them being that medicine, for me, I find is a very rewarding profession. First of all, you work with people, now less so, I guess, in radiology because you're not directly interacting with people, but we work with a bunch of physicians from other specialties who come to consult us for our expertise. But what I'd say the main driving factor is just how wide of a breadth it encompasses, right? So medicine is as much a science as it is an art. And there's not, it's not something in the clinical field, right? So if you're not doing like fundamental research, which is what most doctors do, is just clinical work, then you have, sociology, philosophy coming in, ethics when you're interacting with patients. How should you handle something? You have biology, chemistry, all these things to work out, physics, right? So right now in radiology, there's a ton of physics. But also studying the effects of, for example, radiation on biological tissues and all that kind of stuff. So it's something extremely wide as a field, and that's why so many different fields tie into it. And I find right now in radiology, I also get the whole like visual, the graphics of the image and stuff, which very much ties into my aesthetics of photography, videography, graphic design. Can you
talk about that a little bit? That's another thing I totally wanted to ask you about is the connection between photography and radiology, and for you, right? What is the connection for you between those two things?
I love my specialty, right? So most people don't know exactly what we do in radiology. We're not just
why don't you educate us?
So, even my good friends and family oftentimes are kind of bewildered by what exactly I do at the hospital. But I guess the profession should probably be called medical imaging, right? Medical imaging doctor. Because in fact, when the field first started about only 120 years ago, when X-rays were discovered, it was only radiographs, right? So at first you only had two-dimensional images of the body produced by X-rays, and you would try to interpret that. And at first there were no radiologists, right? It's physicians, regular doctors or surgeons, trying to figure out what was going on with their patient by using this technology. And then fast forward about, 80 years. And then since the 60s, 70s, and 80s, you had the appearance of all sorts of other technologies. So ultrasound imaging, you have CT scan, which is basically X-rays, but three-dimensional, and MRI. And MRI has just completely changed the game because now you can image down to molecular diffusion, which is you can come down to the level of atoms, which is absolutely crazy, without having to open up the, you could always see in the human body before, right? So thousands of years ago, but you had to open it up, which is kind of traumatic. So to be able to look inside somebody with amazing precision and amazing detail without having to harm them, without having to open them, is pretty mind-blowing for me. And
it's amazing. I mean, that was like, Nietzsche's criticism of medicine in the 19th century was, he said that it basically studies things. Whatever you learn from medicine is primarily things that you learn about dead things. And he said, when you dissect something, it's dead, right? Well, now we can, in a sense, we can dissect something when it's alive. We can like look inside while it's still alive, and we can see how those things behave and how they look and how they function, while the organism is still alive, rather than, back in sort of the day of when they were just doing dissections, Leonardo da Vinci and stuff like that, right? Yeah. We don't have to so that is really fascinating. And so what you're doing is exactly what was, I guess, unthinkable for most of the history of medicine, right? So what kind of stuff can you see now, right? What can you detect now that we couldn't detect, let's say, 20, 30 years ago?
Many things have evolved. I think 20, 30 years ago, these technologies like ultrasound and MRI were already around, as well as CT scans. But they've really sort of flown off the charts now in terms of quality and resolution and the speed at which they can be done. So I think, for example, it's better probably to compare to 50 years ago before these technologies were around. How, for example, you had a patient come in, and they have pain. You just have pain in the lower right part of your abdomen, right? And so you're a young dude, you're 20, you have a fever, increased white blood cells, which is the body's immune system. And so we say, oh, this is probably appendicitis, right? Yeah. So there's only one way to figure out is to take you to the operating room, because we'll do an x-ray, but 99% of the time we won't see anything special on the x-ray in appendicitis. So we take you to the operating room, and then, oh crap, it's not appendicitis. It was just, some sort of viral infection, and it's going to go away. Whereas if it was appendicitis and if it didn't go, then it can perforate, and there's quite a high mortality rate, right? Yeah. So now...
And so then you can get an infection in the hospital and die from that. It was... Yeah, cutting you open was...
wasn't a
little
great,
extreme, invasive, right?
So now with we have different modalities, but with most of the people will have either ultrasound or CT scan, and with 99% certainty almost, you can say if there's an appendicitis or not, which is pretty cool, because I forget the stats exactly, but I think it's about 20% of patients or even more who present with signs and symptoms typical of appendicitis who don't have appendicitis, right? So, and it's such a common illness. This is just one of many, many examples. But if you can avoid all those useless surgeries, then that's great, right? So, and if it is appendicitis, you can also say, is there an abscess? Did it perforate already? Is it going to be a hard surgery? So the surgeon can plan accordingly, and ideally it means better outcomes, right?
Yeah. So what are some of the sort of craziest and coolest stories, some experiences you've had so far in the field, like where, something really interesting? Like what are some of the, like if you detected something, early and saved somebody's life, that kind of stuff that would be amazing.
I think every week, honestly, we find but it's a weird feeling, to be honest. Like, it's not to brag or anything, but just by giving antibiotics to some people, like people coming in with pneumonia, which I've done like countless times, this has probably saved some lives, right? But when you're actually working and you're just, like the cheesy, just doing my job, like you actually don't realize what you're doing, right? When you get called at 2 a.m. because the patient has an arrhythmia, and you go and you help them out and you give like electric shock, like you might well have just saved their lives, but you don't think of it that way, right? You don't go back to bed like, I just saved someone's life, you know? You're just like, oh crap, you know, I just want to sleep. Why do they call me? So it's hard to say. And I say like most of these things I forget. Like I see something really cool, really interesting, or I'll you know, like have a patient which will very, very much affect me, and I'll be like very much either charmed or frustrated or whatever. And I'll remember it for that day and the next week, and then I'll forget it. So I don't know. It's hard for me to give examples.
I was talking to a doctor friend of mine once about this, and he said, he said, you know, the difference between my job and your job, John, is like, you have a bad day and, you know, whatever, students have a boring class. I have a bad day and somebody can die. Like I can like make a mistake, diagnose something, misdiagnose something. And the consequences are way more intense because I'm dealing with human beings. The consequences for mistakes are much more intense, right? And that must be, on the one hand, like really sort of challenging and kind of freak you out a bit, but it also must be kind of cool because you feel like, well, I'm actually doing something that matters rather than like, you know, sort of office space, you know.
Yeah, it could be.
I'm just like doing like nothing, right? Like, so it's, I mean, so would you say like, you know, the stereotype is that, you know, doctors sort of get like a God complex, right? After a while. I mean, do you think, well, first of all, do you think that stereotype is true? And if so, do you think it's because they literally are kind of making decisions with life and death consequences on an ongoing basis?
To be honest, I think I'd say no for the most part. And if there are some people who you can clearly see they have a God complex, but it's very much an individual thing and not a systematic thing, because I know so many people that when you actually talk to them, they're like, yesterday I was correcting some cases with my attending physician, and she told me, I found this like super charming. She's one of the nicest ladies and one of the nicest attendings we have. She's like, oh, you know, I don't look like it, but I'm super stressed out and nervous all the time. And I really like, you know, working with you guys because I learn with you, and it's super interesting. And so like that lady for sure is not at all God complex. And most of the people I've seen in medicine are not. Obviously, there are sort of the stereotypical surgeons who are very much sort of impressed by their own accomplishments. But I think those people are also necessary, because when you're a neurosurgeon, for example, and you have to go at 3 a.m. and open up somebody's brain, and it's a life or death decisions and instant reactions that you have to have mastered, you need to be overconfident, right?
Yeah.
Or else you wouldn't do it. So these are things that are just mandatory for the job. And not all of them are like that. I've met like actually most of the neurosurgeons I've met are actually quite humble, but there are some people you just need to be like that. And these sometimes are the people, not always, but these might be the people who will push forward in the field and discover new things because they're trying new things. They're confident enough to do them. Yeah.
Have you read that book by the neurosurgeon, When Breath Becomes Air?
No, I haven't.
Oh, it's written by this neurosurgeon who neurologist, and he figures out, you know, just after he's gone through medical school and he's done all of his residency and he's finally done with all of his work, and he's settling into a nice job as a neurologist, and then he gets diagnosed with cancer, and so he has like just a certain amount of time to live, and so he writes this book while he's dying, and his wife published it. My friend Lavanya, who's actually a listener on the podcast, she like sent me the book. It was absolutely amazing. But one of the things that, I mean, there's a lot of things that are fantastic about the book, but one of the things that was really interesting about it is that it comes through to me, which I don't think I fully appreciated up until then, like how intensely intellectual medicine is, you know, for a lot of people, especially if you're going into like a specialization or something like that, like, because he just talks about loving the puzzle of it and being really excited by, you know, all of these, right? Every single day it's kind of a new thing and you're trying to figure it out. I mean, is that like part of the appeal for you, that kind of that puzzle? Or
Yeah, absolutely. And I think in radiology, I'm sort of talking more about what I know, but For our clinical training, just to be clear, we go through pretty much every medical specialty, or almost. We go through most of them. And so we have sort of, at least a month in every rotation, and we get to see different specialties. So I've had firsthand experience in different specialties, but now as I'm specializing in radiology, I'll give you some certain examples from that field. Well, I'd say every day is exactly what you describe, is solving concrete problems in a short amount of time, and you have a bunch of them. So it's like a ton of puzzles, one after the other, right? So if I'm working on call for a weekend, for example, almost all the cases we're doing are emergency cases. So somebody has an acute problem and they need an answer. And the reason why the other doctors, which are oftentimes specialists or emergency physicians, are asking us for an imaging study is because they don't know what it is, right? So the doctors are dumbfounded, and then they're asking us, which is really what I find cool is we're sort of consultants for consultants, and they send us, a lot of the cases are not, like very exceptionally strange cases, but in radiology, what I find very interesting is we get rid of all the sort of like benign stuff, like, you got an ingrown toenail and that kind of, like common cough, that kind of stuff. Yeah. We get rid of them, and it becomes very interesting intellectually because we have cases, for example, I've seen people come in with diseases that nobody knows what it is, and we actually have very specific findings on imaging studies, and these are diseases that it's about, 1 in a million, and I'm not even exaggerating. So there's some diseases where only 2 or 3 people will have them in all of Quebec, and we all have to know as radiologists exactly what that will look like on imaging study, because if one day they do come into our emergency room and they have a problem, then we'll know what it is, right? Yeah. And we'll help out the other doctors and eventually get that person the diagnosis and the treatment they need. So that's really cool. Every day, and in radiology, what's also fun is that we have a very high volume of cases, patients, studies, whatever how you want to say, but we see many patients, although they don't always see us, because of the fact that we don't, we get rid of much of the administrative stuff, although we do a lot of it, but you don't have to go and ask somebody about their allergies and this and that. You're presented with what you were trained to look at, which is a complex image, 3-dimensional, whatnot. And then we ask you, what's your impression of that study, right? So in a day, we can easily see 20, sometimes 30 cases. Depends what type of stuff we're doing. Whereas in clinical work, you'll see less patients, so you'll also get, less puzzles, right? So for me, it's like as you describe. I think it's very interesting intellectually, because you're constantly solving problems, and these are hands-on problems, and they're not abstract forms from paper pushing. These are actually people with diseases and problems in their life, and they need a solution. So,
yeah, I had the philosopher Daniel Weinstock on here last week, and he was talking about a number of things. He's written a lot on medical ethics, and he recently became vegetarian because he's worried, among other things, he's worried about the fact that all of these antibiotics that they're giving to animals are going into our food supply and our water supply, and they're creating sort of antibiotic-resistant strains of various kinds of sort of bacteria and infections and things like that. So a lot of people say we're going to have another, large outbreak of something, right? And it looks like if there is some sort of outbreak, what I've heard many times is that it's going to be radiologists. It's going to be people like you that are going to see it on people's lungs when they come in with avian bird flu or whatever, the next big thing, right? So do they teach you in medical school or your residency, are they prepared for how we would deal with some sort of big outbreak like that?
Sorry, to a certain extent, yeah. We have public health courses during our general medical training, and then you learn a ton of stuff about epidemiology, epidemics, and what happens. For example, if you notice a case, how to signal it to the public health authorities. And even most people are not aware of this, but there is a big list of diseases in both Quebec and Canada, which are, and even actually at the international level, which are mandatory declarations, right? So I forget what they're called in English because I learned them in French, but They're mandatory. You have to obligatory information of the government, basically.
Okay, so if you have that, it automatically is the information's transmitted. So.
Yeah, exactly. So certain types of hepatitis, for example, and certain a ton of infectious diseases actually, and even some environmental diseases. If you notice like a weird metal poisoning, then some of them are on the list, and these are accessible online. And you have to report them to the provincial government and sometimes the federal government as well. And then there are a ton of nurses and doctors and administrators who look at this at the provincial level. And there are people who do only that. And they basically monitor the statistics of all these diseases. And if they notice weird trends, then an alarm goes off and there's a formal investigation that's done. And these happen actually quite often. Right, we have also during our medical training where I did in Sherbrooke, we have a mandatory public health rotation. And in that, we went to the reunions where they talk about like just animal bites. These are reported actually at the provincial level. And so they talk about, okay, there was this animal bite or certain types of infections, like pneumococcal pneumonia in kids, and then they'll run down the stats. And last year we had 7 at this period, and now we have 8. And okay, this is fine. And then if they notice any trend, they actually do a full investigation, right? And they'll go call call up the people and try to find, for example, it's a digestive tract infection. Then they'll go and look at the supermarkets where people bought the meat, and they'll do tests. And so there's actually all this is going on backstage, and most people don't know that this is going on. And I think these are probably the most important people in healthcare, and they get so terribly underfunded, right? And they actually get, I think it's 1 or 2% of the budget for healthcare, and this includes like all preventative health and all this kind of stuff. And this is by far the most important for actual like population-wise health statistics, right? Because these people are the ones who put on in accordance with other provincial and federal authorities. That the grocer can't just leave his meat out on like a warm counter, right? Like all these kind of silly things that you wouldn't think about. For example, they send actually agents into the very, very, very rural areas, and they look at people's outhouses. Like my uncle has a cottage out in Waterloo, and one day an inspector showed up and told him to, take me to your outhouse and I want to see, and they make sure like it's deep enough, and if it's too full or it's not deep enough, then they make them dig another one. And these are like dumb little things, but they make sure, that the water's safe to drink, that people, like health campaigns to quit smoking or just wash your hands, don't drive when you're tired, or don't use your cell phone while you drive. These are all public health measures, and these are by far, for me, the most important things to actually ensuring health population.
That's interesting. So you actually agree then with Nassim Nicholas Taleb in Anti-Fragile when he argues, because he makes that claim. He says that the medical, as you remember probably, he's very critical of the medical profession and modernity and all these things. But he says that a lot of the credit that the medical profession takes for the fact that people are living longer and healthier, in fact, it has to do with better nutrition and public health and washing hands and having good, sewage systems and things like that. That's actually what is key to this, and they're taking advantage. They're taking credit for something that's not really them. But I remember you were quite critical of a number of things in Anti-Fragile. Do you remember like what your problems with his argument were? Like you. Because I remember we read Pinker's and Taleb, and you found Pinker to be much more convincing.
I've gone sort of full circle on Pinker, but Taleb, I don't exactly recall what it was specifically. I remember one of his passages is like, if you want to kill somebody legally, then just get them a personal doctor.
I don't remember that passage, but it sounds like something that he could say.
I think it's the bed of Procrustes.
Bed of Procrustes, yeah.
But anyway, I think it's him who said that, which I don't totally agree with. But
being a doctor,
yeah.
You're murderer, yeah.
No, but I mean, I think that he in the part that like what we attribute most of the increase in life expectancy, that kind of stuff. Most of it has to do with public health measures, just general hygiene and better nutrition. Vaccination, although some people might hate it, has certainly done much to help it. But I think, regardless of that, there are two issues I think we should touch upon. One of them is that, first of all, people are living increasingly longer and healthier, contrary to what some people sometimes say. We're living longer, but we're always sicker. That's actually not true. For many sort of heart diseases and cancer and that kind of stuff, the average age of onset has gone significantly up, right? So people are actually living longer and healthier if you look at government statistics. Now, however, there are two things. First of all, I think when people come in and they're sick, right? You get a cold, whatever, you want to sort of stay in bed and have somebody take care of you. Well, modern medicine, much of it is that, right? And people, I had this discussion once. I forget who it was with, but this person told me, well, yeah, I understand that, if you wanted to actually save more lives on a population basis, you should put more money into public health. However, people who are paying for it want somebody to take care of them when they're sick, right? And so even if you invest in public health and people start living longer and better lives, one day they're going to get sick. And usually it's throughout their lives at different points and then before they die, right? And so at those periods of time, people want somebody to take care of them. And ideally somebody who knows a thing or two about the disease they have and how to treat it and how to reduce their symptoms and make them more comfortable, if we're talking about palliative care, or how to ideally treat their condition if they have something curable, right? So you can't necessarily say, oh, we should put all our money in public health. This wouldn't work, because people are actually paying the taxes to fund, well, in Quebec it's a public health care system, so people are funding us to take care of them when they get sick, right? So that was the first thing. I have to go back. I forget what the second thing is.
Well, you said you've gone full circle on Pinker. Why have you gone full circle on Pinker?
No, I don't know. I met him actually after after a conference, and he wasn't very. He didn't seem like a very nice person, but this is besides the point. You
met him just like in a meet and greet afterwards,
kind of. I guess it's probably not the best place to meet somebody. I would probably be a dick if I met if I wrote a book and I met people afterwards. After the 50th person, I might be very irritated and not be a cool dude. So, I just remembered the second thing I wanted to say. So although many things in terms of improved health in the past century can be attributed to public health, I think we do have to give credit to what modern sort of therapeutic medicine has done. And I think most people in medicine, we know specifically what our strengths and weaknesses are in terms of therapeutics, right? So for infectious diseases, we're killing it. We're actually winning. In North America and in Europe, we're winning on infectious diseases most of the time, right? Whereas you would have like a 3-year-old girl come in with like a meningitis and there's definitive death, or like permanent paralysis. Now you can treat most of these people, right?
Yeah.
So in terms of infectious diseases, we're good. An important cause for reduced maternal mortality is just better care after birth, right? So we have all sorts of techniques and drugs we can give to stop postpartum hemorrhage. So this was one of the main reasons of mothers dying after birth, and we have a ton of techniques. So now having a mother die of hemorrhage after giving birth is almost unheard of in North America, whereas it used to be just common, right?
Oh, absolutely.
Childhood mortality.
You go into any cemetery in North America in the 19th century, and you see lots and lots of young women in their early 20s, all the way up, and in the childbearing years, and it'll say, died in childbirth, died in childbirth, died in childbirth, and it was just, it happened so often that it actually made women have a significantly lower life expectancy than men, right? So no, that's a big win for sure. And
even certain types of cancers, people are like, oh, when are we going to find the cure for cancer, right? Cancer is not one disease. It's a very heterogeneous and very large group of diseases that just fall under an umbrella term. But we have to acknowledge that certain types of cancer we've gotten very, very, very good at treating. For example, children with acute leukemias, For certain types, the cure rate is 95% and up.
That's amazing.
It used to be inevitable death and within 3 months, and now most of them live. And obviously because they got chemotherapy and radiotherapy, when they're in their 40s or 50s, they're at higher risk to develop certain secondary cancers. But I mean, at least they made it there, right? Kids with cystic fibrosis used to not, there's ads now in the metro, like they used to not make it to elementary school.
Mm-hmm.
And now I have on every week, I'll have a patient with cystic fibrosis, and they're in their 30s, 40s, 50s. This was unheard of, right? These people would not survive. Diabetics, type 1 diabetes, geez, man, all these kids would just die before the age of 10. Like, there's no way to survive. And if they did survive into their early adulthood, they would be so thin and weak that it wouldn't be any quality of life. Whereas now, yeah, it sucks. They have to inject themselves with insulin, but they can easily live until their 60s, 70s, you know, if they follow the regimen properly.
Yeah.
Right?
Well, I know even just with my firstborn son, Tristan, he was born. He had a fairly common complication of birth, right? And it's something that I can't remember the percentage, but it's not like totally rare. It's like a fairly common complication of birth. And up until, for most of human history, even as recently as the 1960s, if you had this complication, almost always the kid would die, right?
Oh, yeah.
And the kid, it was very, very, in fact, I think if I remember correctly, one of the Kennedy kids had this complication and died, even with being, very wealthy and powerful and well-connected and getting the best medical care you could possibly get, right? Died of this. Anyway, he had this complication. They immediately took care of it. They had a whole technique. They brought in, it was like the SWAT team came into the room, and they had him on an incubator, and they intubated and all this stuff. And I remember just thinking at that point, I had been raised to some extent with this really sort of hippie, oh, we just need to go back to before modernity, man. And we just don't need Western medicine and all this stuff. And we can just do it with a doula and at home, with in touch with nature and all this stuff. And I remember just thinking, I'm so glad that we decided to do this in a hospital, because if we had done this as some sort of a home birth, or often a farm somewhere, our son would be almost definitely dead, right? So, and I remember just being really, really thankful for Western medicine and technology, and thinking we take this for granted so much, and it's really, we would miss it a lot, right, if we didn't have it. I think I'm pretty sure you're the one who recommended Sapiens, Yuval Harari's book.
Yeah.
Yeah, you're the one who recommended that to me. Well, I finally got around to reading it, and I loved it. But one of the things that Harari says, as you probably remember, he says that eventually we're going to, in fact, he says we're already coming around to the conclusion that death is basically just a technical problem to be solved. And so he says nobody actually dies of death, right? You die of something, right? You die because your heart stops. You die because you die because of some problem, right? So if we can detect those problems early on, and he says that's really where everything's going, then we can fix those technical problems, and we could potentially live much, much, much longer than we presently do. Does that seem plausible to you, or does that seem out there, utopian, futurist?
I think it's it's probably very utopian, but one thing that I've seen, and I don't know what this is going to lead to, but one thing that I've seen that's perhaps promising is therapies related to aging, right? And we know that most of what kills us is problems related to aging, right? So the incidence of cancer goes up with age, heart disease goes up with age, almost every form of chronic disease, all these things go up with age, right? And so one of the problems with it's common to most diseases is the body aging, and then probably natural defenses and regeneration, all these things go down, and then diseases sort of kick in, right? So a lot of these diseases, like heart failure, it's not something that's added to the heart. It's just the heart's not working as well, right? So if you can stop the process of decline, or if you can slow it down or reverse it even, then you might have a shot at actually living much longer and much healthier. And there are already trials underway. Actually, if you just like the website clinicaltrials.gov is all sort of pharmaceutical companies who have randomized clinical trials have to register their trial on that site. And there are actually trials now for gene therapy and related to certain genes associated with aging, right? And so the hope is that instead of, you have a heart problem and I'll give you a pill to try to make your heart work a bit better, but then your kidneys are going to fail down the line eventually, and then your lungs are going to fail one day. And then, so if you can just treat the problem at the source, then you might have a chance, right? And I think I don't know, to be honest, now it's like an ethical problem more than anything else, right? Because if we do get to that point, it raises a ton of ethical questions, and other people are probably more...
Like what?
Should we, if there was a pill that would make you live 500 years, first of all, would you take it? And what happens, with the population, if everybody starts living that long, and then if the drug is out and it costs a ton, who gets to have it? It's like, and if you, for example, if there was something that could make you, I've seen the term amortal, which is not immortal, but amortal meaning that nothing will naturally kill you. But if you get hit by a car, then, or somebody cuts off your head, then you're going to die. Well, in that case, what happens in terms of, why would you go out and work? Why would you do a ton of stuff? Because now one of the motivations for doing certain things is like your time is limited, right? Mm-hmm. What if you had unlimited time? What's the point of life? Right? I don't know. There's a ton of ethical issues associated with that. And then if, for example, I don't know, just like silly examples, but what about the person who's 90 now, right? They start taking the drug, they're going to stay 90 forever. And the person who's 15 is going to stay 15 forever. I don't know how that will work out.
But there's like some really massive amounts of money on this right now. Like Google has just opened up a whole subdivision that is devoted to solving the problem of death. Like that's
scary.
Peter Thiel has in particular has put a lot of money in this, and right there's some serious, this is not just like wacky people.
No, not at all.
This is like there's some pretty big money in this, and they see it as something that actually could happen. I mean, if Harari is to be believed, and he has a pretty convincing argument, as you probably remember, he says that probably what's going to happen is the treatments are going to be really, really expensive. It's going to be similar to plastic surgery and things like that now, right? Where if you go to, I remember seeing this when I was in Palm Springs last time, that you can see like a huge difference in people's class, what their class they are by the way they look, because the people who have money are all heavily they've got all sorts of plastic surgery and they've had various kinds of things. So they look, you'll meet somebody and they're 55 and they look, 35, right? And then you meet somebody who's working class and they're 35 and they look 55, right? They look like they've had a hard life. And so
most of it is smoking, sunlight, and no makeup. I think that accounts for the difference in age, the appearance of age, at least.
I think I don't know. It could be, more. But his point is that this is going to become a real class thing. And so you're going to have, in the same way that, a couple hundred years ago, you could see the upper classes in Europe were actually inches taller than the lower classes because they had much, much better nutrition and much, everything. So they looked completely different. They were from their size, right, and everything.
So upper class.
Yeah, and so his point is that you're gonna have something similar, right? That there's gonna be a struggle for who gets to be immortal or amortal, as you put it, right?
Perhaps, but I mean, then again, probably the first antibiotics came out and people were like, "Oh my God, this is so expensive, and only wealthy people are going to afford it." And then now with this industrialization and the cost of these things go down, then eventually now you can get antibiotics that cost a few cents to make for a dose.
But didn't the guy who invented penicillin specifically say he wanted this to be like his gift to humanity? He didn't want it to be Remember that correctly? The guy
There's I forget the guy.
he said he didn't want any money from it.
No,
right?
that was one of the guys who made a vaccine.
Is it a vaccine?
Yeah, isn't it the
check
polio
that,
vaccine?
Sebastian? I'm like I can't
Something
remember correctly.
Sark or Salk?
Was it polio vaccine or penicillin? I'm not sure if I'm remembering correctly. But
it's the guy who there's this like meme goes around and he could have made $3 billion or something, but
he decided not to.
Something Salk, I think, Salk or Stalk.
Well, that sort of is an excellent sort of segue into another question I wanted to ask you, which is, what do you think about
Jonas Salk?
Yeah, okay. The polio vaccine.
Too far away.
And he said it was for free.
He I mean, he didn't patent it. He did. I don't think he like made a bunch of it and just gave it away. He just didn't he didn't patent it, and he published his results, which allowed for a ton of different people to be able to make
it themselves.
Right?
What do you think about the relationship between the pharmaceutical industry and medicine? Because a lot of people say that, right now, not as much in Canada, but in the States especially, they say that doctors are basically drug dealers now.
I'm still waiting for my check. It hasn't come along.
Constantly being sent down to all expenses paid vacations in Jamaica with their family, and just so that they can give you a little pitch, on some new drug and things like that. What do you think about that whole relationship?
There's probably a part of truth to it, but the law has changed over time, and there's very, very strict law regulating that. And it used to be, they can pay you, a conference, and it was always under the seal of, for example, we want you to become a speaker at one of our conferences, and we'll pay all the expenses, which they're still allowed to do that, right? And they're still allowed to pay you to go talk on something, but legally, and I think I hope this is what happens. They're not allowed to choose the subject of of what you're going to talk about, and they're not allowed to choose either the studies that you present or the conclusions of your results. However, these people are not stupid, and they're putting their money into something. So, right when the marketers from the pharmaceutical companies choose doctors to go speak for them at conferences, they're going to choose people who they've seen publish, studies in favor of their products or that kind of stuff. So, from the get-go, they try to choose people who agree with what they're trying to sell, right? So there is some bias to it, and obviously most of the funding for pharmaceutical research still comes from pharmaceutical companies. So there's always going to be a huge amount of bias. My only hope for that is that government agencies are going to keep making the requirements stricter and stricter, and have to present all the results and all that. The website I talked about earlier, clinicaltrials.gov, was precisely one of the incentives to try to get pharmaceutical companies from avoiding the publication of failed studies, right? So studies that they want to show that their new drug works. They do 3 studies. One of them turns out positive, the 2 negative, then they don't publish the 2 negative ones, right? So publication bias is a huge problem. So this website, which is a U.S. government-run website, has as a goal to force the companies, if ever they want to register any pharmaceutical product, they have to have already beforehand registered their studies in that registry, right? So if eventually somebody wants to do a systematic review and look at all the studies that have looked at this drug in particular, then they can find them on that website and say like, oh yeah, well, this company, they talk a lot about their one study that showed this result, but in fact, when we go look, there are 2 that they just stopped midway because, for example, more people were dying on the drug. Then, usually, hopefully, the medical community will wake up and say, oh crap, maybe we shouldn't be giving this drug, right? And so, but despite that, there are still many problems, obviously, with the way, for example, they present the numbers, right? Statistics, I think, are mathematical, usually close to mathematical truths, but the way you use them can be very, very manipulative. And one of the common citations in statistics is junk in, junk out, garbage in, garbage out, right? So if you take crappy data, you plug it into a statistical algorithm, you'll get crap out. And so when you have bias in a study, you can't get rid of it, right? So it doesn't matter what statistical methods you use. If the study wasn't done properly, then the results will be crap. Now, like I said, the government agencies have like very, very rigorous criteria they need to meet if they want to eventually have their drug accepted in a certain country. But despite that, there's still a lot of like ratty stuff going on.
Yeah.
And we're stuck also with the legacies of the past. So the studies, for example, like things like Tylenol, right? They never had their due studying, right? They were just accepted years and years and decades ago.
So they're grandfathered in, like.
Yeah. So they don't. I mean, it's like such common use that they don't have to prove anything anymore, right? And the studies that they used back then were complete crap methodology, and
Yeah,
Tylenol.
I remember reading a study of a bunch of allergy medications, and they were looking at a bunch of antihistamines and decongestants and stuff like that, and they were saying they retested them to see how effective they were, and it was absolutely amazing. There was huge variation between these ones that are on the market, things like Benadryl, Allegra, Claritin, all that stuff, and some of them were only effective in like 65 out of 100 people, or 50 out of 100 people, and these were major drugs that were selling a lot, making a lot of money, and they're basically useless to a good chunk of the people that are taking them, right? So it's amazing that stuff like that got cleared.
When you look at it, eventually, I mean, even if you take morphine, which I mean, most people who've ever had morphine for whatever medical reason or recreational use, will tell you that morphine works, right? And it works, right? But there's this, we have this
Morphine's one hell of a drug. Yeah.
There's this researcher in Sherbrooke who studies pain, and he did a bunch of studies on the effects of different drugs and pain and perception and all that kind of stuff. And one of his studies, basically, he gave people just a sugar pill, and he gave other people morphine, but he told them the opposite, right? And then he subjected them to a bunch of painful stimuli before and after the quote-unquote drug.
Mm-hmm.
And what turns out is that even if you tell people that they received morphine and they got the sugar pill, they have less pain. And if you tell them that they got the sugar pill but they actually had morphine, they have more pain.
What?
Which is absolutely mind-blowing, right? So
that makes no sense to me at all. I mean, I know the placebo effect's a thing, but I didn't think it was that much of a thing.
Yeah. And in most drugs, like, you can give absolutely anything and do a study, and you can find that like 30% of people get better in that drug. If you don't have controls, and you'll realize the controls you didn't give anything to, or you give the same placebo, then a third of people will get better, right? Which is kind of crazy. So when you say, for example, the histamine trial, like only 65 out of 100 people got better, that's actually a decent thing, because if you did the placebo, you test it against a placebo, you see that a third get better. Well, actually, your result is a third better. And so you flip that upside down, and it's called the number needed to treat in medical statistics. That's how many people you need to give a drug to get one person better. So you need to give it to 3 people, and one person will get better. And we know that there's no drug that has a number to treat, which is 1.
Mm-hmm.
Right? And the placebo effect always has an effect. And so you can't get a drug that is always effective for everybody. Even for antibiotics for pneumonia, right? Because a bunch of people would get better if you didn't give, it depends like how bad the pneumonia. It's a very bad pneumonia. Almost no one will get better, but there are certain types of sinus infection, right? You give antibiotics, you'll need to give them maybe to 5, 10 people for one to get better, but we'll still consider that being effective, because if we tested it against a placebo, then it's better than the placebo, right? So it's considered to be effective. Whereas if you take, I don't know, a homeopathy drug or a drug that just doesn't work, like any pharmacy, I want to try penicillin for your allergies, right? And I give you penicillin, I give Sebastian a sugar pill. Well,
Mm-hmm.
both of you, your allergies are going to stay the same. So we say penicillin is not effective for allergies, right?
Okay.
So unfortunately, there's no drug that you'll give to everybody and 100% of people will get better. That just doesn't work like that. And it's impossible, right? If you compare it to the placebo, and if there's any placebo effect at all, it'll never be 100% of people getting better on the drug, because some of them would have gotten better on the placebo, and that's how you calculate the effectiveness of it. I don't know if I'm making any sense.
Yeah, no, it makes perfect sense. What do you think, going back to what you said about ethics before, what do you think about the ethics of things like, physician-assisted suicide, and like, what if suddenly that was, if you were asked to participate in something like that, and you were, what do you think about that? Do you think that's?
Yeah, it's a tough question. I think in general, I'd be in favor of it, and the law already has passed in Quebec, and people have gotten already physician-assisted suicide. I'd say for us is during our medical training, we can't partake in it. It has to be doctor like specialist or like family physicians or specialists who've graduated. You need to be done your whole medical training, and then it takes 2 doctors that independently evaluate the patient, and then there are a bunch of criteria, and then it can go through. And the specific modalities of it, I'm not really even sure of. But I've witnessed patients ask for it, and then I've had to ask like my attending physician, this person wants physician assisted suicide.
Wow.
And it's tough, right? It's tough.
Is this like somebody who's like really sick or really old, or what was the situation?
Yeah, it's usually somebody, I mean, like either middle age or old in the most cases. Sometimes somebody very, very young, a young adult, who will have a terminal illness or an illness that has no potential of getting better. And the law right now in Quebec states this as requirements. So, and one of the other requirements is that it has to be sufferable. It has to cause suffering, usually physical suffering, right? And there has to be no way by other medical means to adequately relieve that suffering or bring it down to a level that's tolerable for the person with a disease, right? And so there's like a bunch of criteria, right? So, I mean, probably there are a ton of people who come in and they're suicidal and say like, I want to, help to die. These people are not even eligible at all, right? So one doctor just right away saying no, it doesn't even go through the system. But the people who are genuinely asking for it, I think these people deserve to get it, right? Because the alternative to that is that people go and, I don't know, commit suicide on their own or
themselves, yeah.
And then, dying and the family finds them in the garage or whatnot, and it's very tragic, and it's not a very graceful death, right? The people who are requesting that are requesting dignity in their death. Right? And there's a great Spanish film, I forget if maybe Sebastian could look it up, on this guy. I forget the name of the film, but it's a Spanish guy. It's based on a real story, who became quadriplegic. And he was quadriplegic, I think, quite young adult. And now he's maybe in his 50s, something like that. And he wants to go, it's something about the sea or something. The Sea Inside, yeah. It's a very good movie, actually. See, 8.0 on IMDb. It's pretty respectable. Yeah. It's a good movie. And you see basically this guy's struggle throughout his life with this quadriplegia. And he's actually, I think most of the time he after his accident, he was happy, but eventually he gets to a point where, he just had enough of it. And this is based on a true story. He tries to get help, basically medical assisted death with the Spanish government, and it turns out to be impossible, and ends up committing suicide assisted by a friend. And the movie's nice, and they've covered it quite artistically, but it's kind of sad that he had to get to that, and that he had to ask somebody who, like, as a friend who was not prepared emotionally for that, to help somebody go through that process. I don't know if doctors are better prepared for that. I think there's like it's a very hard act, or very hard judgment call on part of the physician who's doing it as well. And I know doctors like who've completed, and they say, I couldn't be able to do that, right? I wouldn't do it. And by now, like, the law in Quebec, the way it's set up is that you can't, if you're a doctor, you cannot be forced to do it, but you're forced to find a colleague or treat your patient in the meantime, and then find a colleague who will accept to do it, right? So I don't know how many, I haven't looked at the statistics, but I don't know how many have gone through so far in Quebec. It's only probably a handful, maybe a bit more. But it's a very rigorous process, and these people have to be competent. They have to understand the consequences. They have to be very rational. They have to be, they can't be depressed, other than maybe just depressed with their general condition, but they can't be like they can't be psychotic or whatnot. These people are not eligible for that. So I think if somebody in their right mind, very calmly, after much reflection, comes to the conclusion that the life that I'm living now with the disability and the illness that I have is causing me so much suffering that I'm no longer getting any pleasure, or I'm getting pleasure, but I'm getting much more suffering, and I feel that it's not worth it. I don't see why this should be a problem. And I can totally understand why some people might be against it, right? You don't get to choose over life and death, right? But I mean, these people oftentimes have terminal illnesses, would have died a long time ago if we weren't keeping them alive by medical means.
Yeah, no, I completely agree. I think it's a fundamental right. You should be allowed to say, I'm done. You should have that right. It's a very important thing. But I mean, do you think, by the same token, do you think doctors should have the right to just say no, I don't want to participate in this? Do you think doctors should be able to sort of opt out of it? I mean, because that's...
Yeah, and they can now, right? So actually, I think most doctors wouldn't be comfortable
you got to find the right one.
Yeah, you got to find somebody, and eventually you'll find somebody. And usually, you'd be surprised, and I haven't seen anybody do it, but from other experiences in medicine, the people who are doing this kind of stuff are probably the most empathetic, and the calmest or whatnot. I know there's one professor we had, which is a pediatric intensive care doctor, and also he's doing intensive care, and he's also doing palliative care, right, in pediatrics. This guy is he tells you stories of patients he's had, and it's very touching to hear him talk. And I feel as though this might be the kind of person who would do it. Although some of the biggest objectors to physician-assisted suicide are people who already do palliative care, and one of the reasons for that is that they've done this for a long time, treating patients who have usually terminal illnesses, and they're used to probably treating them in a certain way to relieve their suffering, and they have all sorts of different drug recipes and non-medical, non-drug recipes to try to make these people more comfortable and have a better life in their last moments. Mm-hmm. So these might not be always the best people to go through that process, and there are probably certain specialties in medicine which attract a type of person like oncology. These might not always be the type of doctors who want to partake in that, because much of their career is based on, fighting against the disease. And then I've heard stories from other non-oncologists who say, I find it hard sometimes. We're on, multidisciplinary teams, and the oncologist or the surgeon always wants to keep going. Whereas, we're can we just maybe switch to, focusing on the patient's comfort and the person's well-being instead of focusing on trying to fight the cancer or fight, this disease. Yeah. Right. So I don't know which type of physicians do it actually the most, but certainly there's no obligation to do it. And I think that would be completely atrocious if you were obligated as a doctor to partake in it. If your patient asks you, you have to kill them. I don't think many people would go into medicine.
It sort of goes against the Hippocratic Oath just a little bit. Because I remember when I was living in the States, there was this whole controversy because they had the morning after pill was coming out, and there were some physicians and there were some pharmacists who were saying, for various reasons, because of my religious beliefs or, whatever, I'm not comfortable with participating in this. And so they were refusing to give women the morning after pill, even though they had a prescription for it. And this whole controversy. People were saying, well, basically you don't have that. That's not your call. That's my call. That's my doctor's call. And you're supposed to just, you're a technician. That's all you are, right? Right. And this is always kind of a weird thing when it comes to medicine, because on the one hand, you are a technician, right? You learn a bunch of technical skills and you're doing that. But on the other hand, you also are a person dealing with people, and you have to kind of, ethics plays a role, right? And you have to decide what you're comfortable with, what you're not comfortable with. I mean, have you had to get more comfortable with death than you were, or illness than you were, or were you always sort of pretty in tune with that sort of thing?
To be honest, it's hard to say. I think I separate it into my work life and my personal life. And obviously, if I've had several members in my family die, and pets die, and that is always very tragic for me, and I'll be very, very, very sad for a long period of time. Whereas when it's work related, I try to distance myself, and I think most healthcare professionals try to distance themselves. To be honest, probably the people who have it worse and who have the most intimate relationship with death is nurses more than doctors.
Oh wow!
Because in the hospital setting at least, if a patient dies, usually the nurse that's on the ward will have known the patient for much longer time than it depends on where you are. For example, in teaching hospitals, it's always rotating staff, especially in terms of the medical staff, whereas the nurses oftentimes will have like a position on that floor and that, in that sector of the hospital, and they'll get to know the patients much better. And so, for example, when I'm usually when I've had to, for example, I don't know how you say it, but in French it's like constater, like when you have to sign the papers to say that somebody's deceased, right? So I've had to do that a few times, and when I've gone, most of the time it was people I didn't know, right? And so I'd never seen them before, but it happens that I'm the resident, the doctor on call,
the attending physician,
right?
Yeah.
So I'm there, and I have to cover the whole ward, and so basically I go, but I have to explain to the family, like talk to the family and offer my condolences, but I've never seen anybody there, right? Whereas the nurse who's gotten to know the patient for, he's maybe been there or she's been there for 2 weeks, and then they're often the people who will discover, the dead person as well too, right? So they go, and at that time, like now the person's deceased, and they have to like go and get the family, call up the people, and then eventually too, like they sort of clean them off, right? So the doctor goes and just, like this person's dead, right? No pulse.
Okay.
There's you have to.
Your parrot is dead.
Yeah. So I mean, it's not like for us, it's not that bad. And then the nurses have to come and like clean them and take out the catheters and that kind of stuff. Like
they clean the body afterwards.
Yeah, because it's like as I don't know, out of respect for the family. Oftentimes, if the person is like kind of like not well presented, they'll try to present them well so the family can spend a bit of time with them, and then eventually they send them to the morgue. But for us, like, it's mostly brief experiences, and this is a general rule. I mean, obviously I've had patients like in the ER, they come in and they die right away, or they come in and they're dead, and you're trying to like resuscitate them, or patients die on
You've
the
been
operating
there for that?
table. Yeah.
Oh wow.
So,
and that's like on a weekly basis.
Well, not really anymore in radiology, and not when I was doing like
when you were
family medicine in the countryside.
Yeah, but
in the hospital, when you're in the ER, it can happen relatively regularly. It depends where you are too. Like there are hospitals where they send more certain types of patients, right? So like the CHIM right now where I'm at, it's like very very big neurology and neurosurgery center, whereas you have Sacré-Cœur, which is more in the north west side. That's more like trauma patients. So you'll have a different type of patient where they have, like the Montreal Heart Institute obviously gets a bunch of people with heart problems. So cardiac arrest is quite frequent there. So it depends where you are. But yeah, these are the types of things you see. And I think it's a very strange feeling, right? Because in a sense, yes, it does affect you, but when you're working and you're there, like your mind is trying to say like, how can I help this person, or how can I solve it? And you need to distance yourself emotionally if you're going to do any job at all, right? And I've seen it, and like the first time it's happened, you sort of freeze up, or it depends, probably from a different person to another, but you oftentimes sort of freeze up and you don't really do much, right? And luckily there are colleagues there to help you out. If somebody's like, if the goal is not just to pronounce somebody dead, but to actually try to help them come back to life, then that's quite different. But I feel as though like one of the craziest things that's happened to me is when I had this guy come in and he just had basically stabbed himself a ton of times. Oh. And that was like really, really scary. And that sort of traumatized me
he stabbed himself.
Yeah.
So like, was he going through psychosis?
Probably, yeah, probably.
Wow. And so what? I mean, did he make it?
Yeah, he made it. Luckily, he's like 2 millimeters away from his carotid, and like his chest was open, his abdomen. It was like really horrible. I don't want to go into detail, but it was really like that was one of the most traumatizing things I've seen, more than actually seeing somebody dead, because that's like that's very traumatizing. How in your right mind could you imagine doing that to yourself?
Stabbing
right?
yourself that many times.
And I've had other colleagues that's happened to them too, like see people come in like that. So it's actually not that rare of an occurrence as you might think. Like really weird things you see when you practice medicine. Like you'd be surprised how often people say, quote unquote, "Oh, I fell on this lemon or this cucumber when I was gardening naked." Yeah, so
for an extraction,
medicine,
right?
yeah.
The GI Joe, like
Yeah.
up the butt or something like that. Yeah, like
So you see like really weird stuff. This goes back to what I was saying earlier about how you try to forget, you know? So like most of my day and most of my week, now I'm talking about it, I'm trying to find, because you asked me for like memorable stuff.
Yeah.
But most of the time we don't think about that, or we'll sort of like forget this stuff. And the same goes, I think, for all like the death and dying part. Sometimes it can be like very nice and graceful, you know, when you accompany, for example, a patient in palliative care, and they have a terminal illness, and you follow them and go see them every day, and your goal is to make them comfortable, and eventually after a few days or weeks then they pass away. That's like, it can be a nice experience, and then the family is like almost takes you into the family and say like thanks for helping them, and like you get hugs from the family. That's like a very nice experience. But then you have like the young mother who comes in and just like suddenly like had a bleed in her brain, and just like she dies there in the emergency room, and no one even knew she had any problem at all, right?
Wow.
She was healthy, she comes in and she's dead, and you see the family devastated. And that's like, it's crazier than what you see on TV, right? It's like, it's giving me shivers, right? So it's very variable, the experience of death. And it's certainly not as graceful as what you see in movies or films.
Yeah.
And then like on TV, right? It's not like Grey's Anatomy, like, oh no, it's like very dirty. And CPR is like gross, right? Ribs get broken, people are coughing up blood, and
Really?
like, yeah.
Oh wow.
So it's not, and people are pale, right, or blue, like it's very morbid. It's very scary, right? So, and
Wow.
movies usually don't show that.
They don't look-
Luckily, because
yeah.
I think most people wouldn't be
one of
comfortable.
One of the things that's always kind of fascinated me is the relationship between training for a particular profession or job or whatever, and doing the actual job, right? And so one of the things that I've heard from a number of people, most recently from a friend of mine who teaches at McGill and also has, he said, well, you know, one of the problems we have with medical school, and I want to know if you agree with this and what you would say about this. So one of the problems we have with medical school is that it's incredibly competitive to get in, especially to the top medical schools. It's very, very competitive. So we have this environment where we teach young people who are very high performing, kind of smart students to just be really kind of cutthroat, and you're trying like to get ahead at any cost, and so those are the people who end up, and I've definitely seen this in students, the students who want to go into law school or medical school are, you know, they're often quite bright and they're very motivated, but they're not always necessarily the most ethical people, right? So anyway, so what I've heard is that you have these people who self-select, who are quite, they're very motivated and but they're a little bit cutthroat, and and those are the people who get into medical school, and then they are encouraged in medical school to be that way. But then when they finish and they go into the actual profession, well, in the profession, you're in a situation where you have to work with other people a great deal. You can't be just totally out for your own glory all the time. You have to work with other people. And you have to deal with patients and with nurses and with fellow physicians and with families. And so anyway, his argument was, he thought, because we were talking about that show House, right? And he said, well, you know, he said some things about that show obviously are just sensationalized and not realistic. But he said one thing that is kind of realistic is that the way the profession is set up is that right now it tends to attract a certain type of person, right? A very super, super competitive, maybe to some extent like a high functioning autistic type person who is but those people end up having a skill set that's problematic when you get into the field. I mean, has that been Have you noticed that there's a kind of maybe a little bit of a ruthlessness to the?
Not really, actually, quite to the contrary.
That's awesome.
I think because I heard you talk about this on another podcast.
Yeah,
and I was happy to be, I'm happy you're asking the question because I would have liked to respond back then. Actually, I might be biased because I was lucky enough to do my medical school, my general medical training in Sherbrooke. And so Sherbrooke has long been very avant-garde and very much different in their approach to teaching medicine. And since the 70s or 80s, they always teach by like 90% of what you'll learn is by small groups. So you're only 8 people in a class with a doctor.
That's fantastic.
Almost all the learning you're doing it, well, not all the learning, but I mean, you're reading up before the problem, right? So you're presented with a problem. It's like an actual patient situation. So the man comes in, he has chest pain, blah, blah, blah. And then you make these hypotheses. So this is, you'll say, oh, I don't know, like how does the heart regulate its own blood supply? I don't know, whatever kind of.
So it's like straight up apprenticeship.
And then you go read on that. You have like 2 or 3 days. And then you come back and then you discuss, you go over the problem and the doctor, the physician is there to just guide you through and then if you say something wrong, then they'll correct you. But if not, like it'll be somebody explaining to somebody else and whatnot. And so this is like we call it the preclinical training. It's 2.5 years, right? And then for where I was in Sherbrooke, there wasn't much competition that I could feel. Obviously, for people who want to go into like a specialty, for example, I give like the most blatant example, but neurosurgery, there's one spot, in every university in Quebec. And now for the next 3 years, there's one spot in all of Quebec, right? So if you have 2 people who really want to go into like a hyper-specialized domain, then yeah, there might be competition amongst these 2. But most of what I've seen, and especially when you start, you're really not sure what specialty you want to go into. And oftentimes people come in thinking like, oh, I want to go into cardiology. And then they do a rotation like, I hate cardiology. And, because there's a very big difference between the theory and the practice. You might find the theory, I find like the theory of chest physiology, like respiration, all that kind of stuff, very interesting. But when you become a lung respiratory doctor, a pulmonologist, then it's mostly people who've smoked all their lives and now they come back for like recurrent infections. That's that or lung cancer because they smoke too much. That's most of your work, right? And so you're like, it's kind of hard. These people are just coughing up pus all the time. It's kind of gross. So, I mean, this is like whereas like when you read about it, it's like all these rare diseases and like how the lung works is super fascinating and how it exchanges blood and all this, right? So this is how basically you go through 2.5 years of mostly theoretical stuff, but where I did my training, you also have sort of small rotations throughout that, and you have patient encounters with actual people, where you're always supervised by a physician, obviously. And throughout that training, I find that most people were super nice to each other, would share notes. We had a Facebook group and we would be like, oh, look, I found this, where everybody's doing the cardiology module. Well, I found this great site that just sums up like the recent recommendations on how to treat, a heart attack, right?
Fantastic.
And people are like, oh, here, I took some notes during the class if anybody couldn't attend, right, today. And so there's like people who just really help each other out. And then we have like all these question banks of like exams from the previous years and just like, we're not supposed to talk about that, but then here you go. Yeah, and everybody would be just sharing the stuff. And there's obviously a few people in the group who are sort of like very competitive and outcasts. And I think there's a way to be healthily competitive.
Sure,
right? So I didn't feel it was cutthroat at all. And then after that, you have 1.5 or 2 years of clinical rotations. Then people sort of spread out throughout different hospitals and different services. So you're not really that many people. And then in those rotations, if you're like, I don't know, if you happen to be 2 people in the endocrinology rotation and they both want to really go into that specialty, then yeah, maybe you might see some people being kind of dicks and like trying to shine. But I'd say, to be honest, like when these people try too hard, everybody notices, and even like mostly the evaluating physician notices. And they'll usually meet them and be like, look, like you're really trying to like outshine the other person. And it's really not cool because that's not how it's going to work later. And they get bad evaluations if they do that.
Wow.
Like people who try to like be like ass kissers actually get scorned for it. Right. So
wow.
It's not like that. And right now in my program, Montreal is like relatively competitive radiology program. And I don't get that feeling at all, right? So I'm more interacting with people from my year, and we turn out like to be a good bunch, and we're all good friends. So we help each other out. We also have a Facebook group where we share stuff and advice, and we help each other out. So it's not something I've really had to deal with much.
Okay, I also had two questions. Sort of, first of all, what would you say to young people who are thinking about going into medicine? What is something that you wish somebody had told you before you went into it, like something that you did not anticipate, which you would have liked to know? Is there anything that you can think of that, what it's actually like that you didn't anticipate?
It's not like on TV.
Well, I hope most people figure that. I mean, I don't know if they're wanting to. I know,
one thing I might say is, and this is one thing that kind of upset me when I started doing clinical rotations, is precisely to the point where you said, modern medicine has become very cold and, sort of like very specialized, and maybe sometimes patient care and, warmth towards people has gone out the door to leave more room for technology and that kind of stuff. One thing I found which kind of surprised me is when I was doing all these clinical rotations. I'm in internal medicine, and you're supposed to be Dr. House, right? Internal medicine. Well, it turns out you really don't spend much time with patients, right? So I thought I'd be, going out and talk to the patient and, examine the patient. But it turns out much of what you do, because people have sometimes such complex medical histories and have had so many tests, most of what you do is actually looking at old charts and old notes and trying to understand what's happened to the person before, and then ordering more tests, and then looking at the results of those tests. And then, the person has to see a physiotherapist, and so fill out the request for that. And then, they need to go to, how do you call it? Like réadaptation. I forget what
rehab.
Rehab, right? So
physical
to
therapy,
get physical therapy, right? So you need to meet with a physical therapist, and then you need to have this multidisciplinary reunion. So most of the time you're not actually with a patient. And people might find it shocking, but this is one of the reasons why I went to radiology, because I realized that most of clinical quote unquote work, where you're supposed to be seeing patients, you actually don't see patients that much. You're doing so many other paperwork, and then you got to fill in notes, and then you got to copy the lab, the lab results in your note to show that you really actually checked everything and you're very systematic. And then eventually you go back to see the patient 2-3 minutes, and you're in a rush because you have a ton of other patients. And you're just doing that fast, but where you can't skip out is to actually look up the chart, because I don't know, if the patients, if it's somebody who comes in with chest pain, and no, I've never had any surgery, and you look and they've had coronary bypass surgery twice, this is a very common occurrence where people, you might be shocked, but people don't know that they've had their gallbladder removed 5 years ago, that kind of stuff. So you need to go through the charts all the time, and you need to do a bunch of paperwork. So you end up not seeing patients that much. And I told myself eventually, if I'm not going to be seeing patients that much, might as well just skip all the freaking paperwork and going through charts. I'm just going to go, that's not why I went to radiology, but I was in radiology, at least I see an image and I can understand there's there's old imaging and old results, but I can look and I can see a lot of stuff and understand a lot of stuff without having to go through so much paperwork. Right.
Yeah. But that seems to be something that's happening in a lot of professions. Cause I know when I talk to former students who are in law enforcement, they say that these days, for a 10-15 minute interaction with somebody, they can easily have 2 hours of paperwork to fill out. And for some going for a domestic sort of violence call, for instance, they can easily sort of have an interaction that's a half an hour, and then be staying at work filling out a report for a really, really long time. And they say, watching cop shows and watching things like that.
They said, cut out all the boring part.
You said, the cop shows are really gritty now. So they include a lot of the difficult stuff. But what they don't show is you spend a lot of your time just doing paperwork, really, really boring amounts of paperwork. So I'm that's interesting. In medicine, it's the same thing. And sort of a related question is, if you could say one thing to our listeners, who are the majority of which are not doctors, right? So to people whose experience of medicine is as a patient, what is something that you think that patients need to know? I mean, you mentioned before about how, show up to your appointment. Show up to your, is there any other stuff that you think patients should know, like some tips to getting better care? Or
I think one of the things I think maybe people should be aware of is that, well, obviously people are aware of that, but I'd like to remind people that we're human too, right? So sometimes, I've had several times.
You are. Yeah.
For now. I've had, like people complain about sometimes, seeing like, oh, he looked so like tired and so, like he looked like rude. Well, you got to understand that when you're like 20 hours into your 24-hour shift, or you're just been working so hard, and you go and you actually still want to like care about what's going on, but sometimes it might show in your face that you're you're exhausted, right? And I think that I'm not trying to, when you go to the hospital or you go to a clinic, it's because you're sick, so you don't want to have your doctor's problems. But understand that like most doctors, and the vast majority, actually care about their patients, are actually good people. And I think most of them too actually went in for the right reasons. And I bring this up because really recently there's a lot of, at least in the French media in Quebec, there's a lot of doctor bashing and complaining like the salaries and people, like the shit service people get. And I don't know, from an inside perspective, I'm at the hospital usually 6, sometimes 7 days a week, and working 10, 12 hours a day. I see like we're working hard to try to help people out. And despite that, I don't know why, like I said before, I don't know what the problem exactly is with like the wait times and that kind of stuff. But like, when we're there and we're working, I think most doctors are like actually genuinely want to help people, and they went in for the right reasons, and they're going in every day. And despite, the woman, I can have a patient, for example, who just like dies in like the waiting room. And like 10, 15 minutes later, I'm expected to go see somebody else and be like all smiley. And this has happened several times, and probably to all my colleagues, right? And you're supposed to go from a young person who just took 200 Tylenol pills and who's like dying of liver failure, and then you go see the other person who has a common cold and who just came because they have a runny nose. And you're supposed to be like, and most of the time you are like, you're very professional, but sometimes it sort of shows that you're, come on, man. Like, why are you clogging up the waiting room, right? But we won't say that to people, because people are worried, and that's why they came to the emergency room. And you can't blame somebody for being worried, and it's all right. But I mean, I think there's been a lot of doctor bashing recently, and I feel a lot of my colleagues and a lot of the media, like at least doctors, have been responding and saying like it's bringing our morale down a lot. And this is and I've noticed this in a lot of people. A lot of my colleagues, how they sort of like feel increasingly hated by society. There's like a ton of articles on doctor bashing recently in the Quebec French media, at least. Like I said, I don't read much of the English one, but it's mostly have to do, I think like a lot of it is frustration with the wait times and overall jealousy. French Quebec has always been about like a good Catholic, you should be poor and happy to be poor, right? And so anytime somebody's making money, it's like seen as bad thing, right? So you're like obviously doing something bad, or you're a crook, right? If you're making,
if you've got money, you stole it. Yeah, like that's what I grew up hearing all the time.
So,
well, that's an excellent place, I guess, to end up. I just want to say in Plato's Symposium, the really boring guy at the table is Eryximachus, who's the doctor. And you are not at all boring. It was really, really, really interesting talking to you. And thank you very much for coming on the podcast. And thank you for listening, our listeners. If you'd like to support the podcast, there's a number of ways in which you can do that. You can like us on iTunes. You can share the podcast on social media. You can talk about it in your blogs if you have one. You can also support us directly by, and I know I'm going to mess this up, Sebastian, again, our Patreon account. Did I pronounce it correctly?
No. Patreon.
Patreon. I've got like a mental block. I always mess that up. So you can also support us directly by contributing to our Patreon account. Did I get it right? Oh, I got it right that time. Anyway, have a great time. Thank you for listening.
Thank you.
Bye.